Hello, my name is Jenna Gregory. I'm a senior clinical lecturer at the University of Aberdeen, and I actually work as a researcher in motor neuron disease. We actually have some funding from MND Scotland. We're very happy to be sharing some of our work with you today. Part of my job is actually as a doctor in the hospital, and part of that job is I'm a pathologist, and most of my work in pathology is actually doing diagnostics on cancer specimens, so people who come in for a diagnosis of cancer, and how we go about putting people in the right clinical trials, making sure that they're getting the right treatments. And that isn't actually part of a lot of the work that we do in MND, and it's something that I'm particularly interested in, taking my experience of cancer medicine and translating it to MND to improve medicines, to improve the way we treat people and how we get people into clinical trials to make sure they get the right treatments. Something that I've been reflecting on recently is actually how much cancer medicine has changed, really. And if I think back to 20 years ago when I started medical school, cancer was a completely different disease. Really, it was terrifying to have a diagnosis. It is still now, but actually there's a lot more hope in that field. And we need to think about what we've done well in cancer that's really made that transformation happen over the past 20 years to something that is essentially treatable in a lot of instances. And we need to translate that to MND, and that's something that my research lab and my research work is particularly focused on. And so thinking about what we've done well in cancer and trying to do that in MND, this is something that I'll talk about on this slide. So 2 strategies that cancer medicine's done tremendously well that we need to be doing in MND are so things called precision medicine and precision prevention. So what are these things? So precision medicine is making sure that we give the right person the right treatment at the right time. And so this is basically where we take a patient population and we understand that actually instead of just treating everybody with the same drug, which might not work and certainly didn't work initially in those very early cancer trials, actually what we need to do is have a more tailored approach where, for example, the people here in blue on the top line have a different underlying cause for their disease to the people in grey. And we need to recognise that. So, for example, if you have a lot of inflammation and that's what's driving your disease, then you need an anti-inflammatory, but somebody else who doesn't have that inflammation might not. And so we need to think about these different causes and tailor treatments to the underlying cause rather than the disease umbrella of MND. And we've done that really well for cancer, and we're actually starting to do that much more for MND, and particularly thinking about these inflammation-driven clinical trials that we're doing currently. But something else that we need to do in MND that we're not really doing at all is something called precision prevention. I'll talk about some examples of this that you'd be very familiar with on the next few slides, but actually it's something that we really need to be thinking about for MND. This is slightly different to precision medicine because what this needs to do is think about how different people in the population may have different risk factors for disease. So, for example, if you have a genetic mutation that increases your risk of getting MND, you might need a different preventative strategy to somebody who has a disease caused by something else. So, for example, a head injury or a trauma or something like that. So this, instead of thinking that the cause is different for different people, this is talking about the fact that risk factors of disease are different for different people. And that actually, instead of just having a standard approach to prevention by saying, you know what, you need to eat better, you need to exercise more, doesn't really work very well. But actually what we need instead is a tailored approach. So for your particular risk factor, you need to be doing this, you need to be doing that, and thinking about how we can tailor that. So precision medicine and precision prevention strategies are really important to our research in my research lab, and really thinking about how cancer has done very well and translating that to MND. But why is it important to think about precision prevention in MND? Well, let's take cancer as an example again. So on the left, these are actually 2 infographics that are available on the Cancer Research UK website. And when I saw them, I was totally struck by this data that they're presenting. On the left, what you can see is the 3 most common cancers, so lung, bowel, and breast. And what it's showing is that if you diagnose in the earlier stages, so on the left, breast cancer is pretty much treatable now. Almost all breast cancers are cured with treatments that we have. 90% of bowel cancers are, 60% of lung cancers are. So we're doing so much better than we were 20 years ago, where almost none of them were. But look at this on the right-hand side of those images. You can see that if we diagnose cancer at the later stage, we're still terrible at treating cancer. So less than 1 in 10 people diagnosed with late-stage lung cancer, it's curative. So we can't really treat in the later stages of disease, but we're much better at treating in the earlier stages of disease. The second thing that struck me was when I saw the diagram that's on the right-hand side of this slide, how and when cancer patients are diagnosed. And actually what you see is that the majority of patients, so in the dark blue and the blue, the two blue boxes and the pink box, all the boxes at the top, that's most of the patients with cancer are diagnosed in the community. So either in A&E, so not really in the hospital outpatient setting, in A&E or in the GP surgery, or by screening programs. That's how we're diagnosing cancer. That's why we can pick it up earlier, because we're diagnosing it in the community. If we wait for hospital outpatient diagnosis, it might be too late. And that's actually what we recognize with cancer, and we've shifted towards this community diagnosis. Contrast that with MND. Everybody with MND receives their diagnosis as a hospital inpatient or in or outpatient. So it's a very different thing that we're doing in cancer that has made it be quite successful really in the past 20 years that we're not doing in MND currently. And this sentence at the bottom, I think, is just the most striking take home from these images, really. When I'm thinking back about that 20-year progress that we've made with cancer, we didn't get better at treating cancer. We got better at diagnosing it. We got better at diagnosing it in the community and early so that we can intervene early. We're still not good at treating cancer if it's in the later stages. And we need to completely shift our thinking for MND to be able to diagnose people in the community early. And so here's some examples of precision prevention that we do in the community, in our day-to-day life as clinicians, as doctors, that we manage regularly. Okay, so these are all diseases that we have prevention strategies for in medicine. So for example, stroke. High risk of stroke if you've got high blood pressure. That's why your GP is desperate to test your blood pressure, because if you've got high blood pressure, we need to be treating it because it can lead to cardiovascular disease, stroke, kidney disease. So we need to recognize that the risk factor for stroke is high blood pressure and treat it. And we already do that very well. Colorectal cancer is another one. So everybody over a certain age in the UK will have a screening test done where they have a stool sample that they send off in the post that gives them a risk, understands their risk of developing colorectal cancer. If you're high risk, you will then get a colonoscopy where we can have a look for things that could turn into cancer, so polyps that could turn into cancer, and we remove them. And if we remove that polyp, we remove your risk of getting cancer. And so this prevention strategy is safe, it's tolerated very well, and we do it for a lot of people in the UK currently. Diabetes is another one. If you go to your GP, you're feeling tired, you're urinating frequently, you'll have a blood sugar test done. And if you are diagnosed as pre-diabetic or diabetic, we then initially start you on diet control, so dietary advice. So again, a safe intervention. These diseases that I've highlighted in boxes are actually interventions that we do preventative strategies for that are super safe. And the ones that aren't in boxes are ones that we have prevention strategies for that aren't so safe. So for example, breast cancer, we know that if you have a particular genetic mutation, a BRCA mutation, you have a really high risk of getting breast cancer. So high, in fact, that we offer a double mastectomy, so to have breast tissue removed. And so that clearly isn't a safe, straightforward preventative therapy. But ultimately, the majority of diseases that we have an understanding for that we treat routinely in the community, we actually have very safe precision prevention strategies. So I've talked a bit about prevention on this slide, but what do I mean by precision prevention? So precision prevention takes something like stroke. How do we prevent stroke? So say, for example, one of the risk factors of stroke is blood pressure. We don't give the same treatment to everybody for blood pressure. We actually do it in a very precise way. So when you go to your GP, they actually have this chart, and this is how they're going to manage your blood pressure. So if it's a bit high, they're just going to follow you up over the next 5 years. If it's a little bit higher, they're going to do something different. And if it's very high, they're going to do something different. So if your risk factor changes, if you've got very high blood pressure, you've got a very high risk of having a disease. So they're going to treat more aggressively than if it's low. So we have this strategy to diagnosing people. And then the treatment that they pick is also another chart where they say, if you're over 55 or under 55, you'd get a different medicine. If you've got diabetes as well, you might get a different medicine. And so the way we diagnose people, what we do, and what treatment we give is very much dependent on the person. So precision prevention, and this is to prevent cardiovascular diseases and stroke that happen because of blood pressure. And we really need to be thinking about these precision prevention strategies for motor neuron disease. So if we're going to do that for motor neuron disease, what do we need? What did cancer have initially when they started rolling out these sort of strategies? What we really need is readily accessible tissue and samples, so tissue for biopsy, readily accessible. The brain is not easy to access and it might be too late. So we need something that's readily accessible. We need biomarkers. So what do I mean by biomarkers? I mean tests. I mean tests that can be done in the community as screening tests or in the GP surgery. So, for example, a urine test for an infection or a stool test for the bowel screening program in the UK. So we need something that is an easy to implement test, something that can be done in the community, either as a screening tool or in the GP surgery. And then the final thing we need is we need to know what these risk factors are, and we need to be able to treat with safe medicines. So safe approaches. So going back to that original slide, anything that's in a sort of square box, those safe therapies, safe medicine, safe approaches, lifestyle advice, things that we can do to improve people's risk profile for MND, stop people getting it. So to start, so what I will do is I will talk about each of these three things in turn, just a slide on each, just to talk about how we could do this in the context of MND. So first of all, let's think about tissue that's readily accessible. So the brain isn't readily accessible, but we published this paper last year where we actually looked at tissue that had been taken from people who went on to develop motor neuron disease during their life. And what we found was that you can actually detect the signs, the protein clumps that cause motor neuron disease in the brain. You can actually detect those clumps outside of the brain, even years before people get their symptoms of motor neuron disease. So we found in this study that you can actually, so there are organs in the body that you can't detect these clumps, these protein clumps of motor neuron disease in, but there are some that you can. So for example, you can't detect it in the bladder, and that perhaps means that maybe urine might not be a very good test. But look, you can detect it in the gut, in the colon, in the gallbladder. So that means that things like stool samples might be useful. You can also detect these clumps in the skin. So people have evidence of motor neuron disease in their skin years before they get motor symptoms of motor neuron disease. And this really changes the way we think about MND as something that we could prevent, because we know years before people get symptoms that we can detect it. Then we can start thinking about treatments and ways of preventing it. This is an example of one of the samples that we looked at in this study, and this is an image of the colon. So this is somebody who had a colonoscopy and had a biopsy taken, a tiny bit of colon tissue taken. And it was reported as normal at the time because this is a normal colon. So these nice structures, that this is completely normal, and you've got these inflammatory cells in between them. And so what we're looking for in these biopsies is some evidence of why this person's got really bad gut upset. And this person didn't have anything that we could see on our routine stain, which is this pink and purple stain, a hematoxin eosin stain. This is our normal go-to routine stain. However, at the time, and this was taken 2 years before this person got motor symptoms of their motor neuron disease, at that time, because we were just looking with the pink and purple stain, we weren't staining for the clumps of motor neuron disease, but they did actually have those present at the time. So these tiny brown dots that you can see here, these are the same as the brown dots that appear in the brain, this protein, this TDP43 protein that accumulates in the brain causing motor neuron disease. We could have detected this 2 years before they had symptoms if we'd stained with their gut tissue. So readily accessible tissue for biopsy, we perhaps need to be thinking outside of the brain. The gut and the skin represent really easy to biopsy sites, and not just for biopsy for taking pieces of tissue, but also for tests. So really, if the gut is involved, then we're talking about stool tests. If the skin is involved, then maybe we're talking about skin swabs. And we need to be thinking about ways that we can use that to prevent people getting motor neuron disease, to detect early, to push MND into the same space that cancer medicine is in now, where we're detecting early so we can treat better. So the next thing I'll talk about is biomarkers, so these tests. So what we need is a better, more accurate test for motor neuron disease. This diagram that I designed a while ago just sort of helps to explain what we need to do. So normally, if I want to detect this blue squiggle, which is the protein that causes motor neuron disease, TDP43, I can use the brown stain that I showed you from the gut stain, not the pink and purple one, the one afterwards, the brown stain. But that's because you get this brown stain to bind to this little yellow bit of the protein, and it is able to detect it. The problem is that when I showed you those lumps, those clumps in the gut and in the brain, actually they're quite large lumps. They're not this long string. So actually it's very difficult to get this to bind to this yellow bit. Actually what ends up happening is that it can't bind. It's buried within the clumps. So instead we designed something called an aptamer. And an aptamer is a new test that you can implement. It's actually being implemented in cancer medicine already. We've just modified it to be able to bind to the protein that causes motor neuron disease. And instead of you needing to have the protein all unfolded to be able to see it, it'll actually just cover the surface of these aggregates, these protein clumps. And so because it can do that, you get really good resolution, you get really good accuracy of being able to detect the protein that's causing MND. And so here's a couple of examples. So on this side, on the right-hand side, is when you use the classical approach. That's the one at the top. You can see nothing in that one at the top. And then just to the left of it, you see this tiny little pinprick, and that's because that's the aptamer stain. So the aptamer is detecting something when we couldn't see something before. But even if we can see something, so the box at the bottom right, this sort of grainy pixelated box, if you use the aptamer, so covering the surface like this, you can actually get really good precise surface structure. It's totally different. And really this aptamer then allows us to have this increased accuracy, improved precision to be able to detect these proteins that cause motor neuron disease. So what does that mean? That means that if we think about motor neuron disease as a systemic disease that we can actually detect in the gut or in the skin of people years before they have symptoms, if we can detect it in the gut, that means that we can think about stool samples. If we can detect it, this picture at the bottom in the middle is actually a blood vessel. If we can detect this protein in the blood vessels, that means that we should probably be able to detect it in blood samples. And so thinking like this, we can now start to think about diagnosing people early, shifting towards that success of cancer medicine. And what we're doing at the moment is working with LifeArc to try and develop stool and blood tests that could be implemented in the community. So something straightforward like a lateral flow test that we've been doing for COVID, for example. Something straightforward to be able to detect these clumps that cause motor neuron disease in samples that are easy to access. So you don't need to go and have a spinal tap done to be able to make that diagnosis. That means that we can really armor our GPs and our screening programs to be able to make these diagnoses early. So I've talked a bit about gut and skin representing easy to biopsy sites and a little bit about how we can use new tools like aptamers that are already being used in cancer medicine, and that these can help us to improve the accuracy of those targeted tests. But what about identifying risk factors? Risk factors that then we can treat with safe medicines. So a really good example is this paper that was published. I love this paper. They're fascinating work that was done in Korea. They took a group of people who had been diagnosed with ALS. They then looked at what their diet, the differences between their diet, and saw whether that had an effect on their progression and their symptom progression. And they actually looked at fiber as one of those markers. And what they show, so in this graph on the left, what it means is if the line is at the bottom, you're doing worse. And if it's at the top, you're doing better. So this is survival. And what it shows is that if you had a lot of fiber in your diet, you actually survived longer. And that's the case for total fiber, but it's even more the case for vegetable fiber. And so really, we're starting to think about whether if we can detect something in the gut, can we then give dietary advice to improve vegetable fiber intake, for example, starting with safe preventative strategies. And it doesn't need to just be safe preventative strategies like improving vegetable fiber. It could also be drug treatments, because if we have a test where we can actually measure the amount of these protein clumps in the stool sample, for example, we can then see whether drugs are working. We can see whether that drug that we give you can remove those protein clumps from the gut, and hope that that then improves the brain function as well. So I've talked a bit about having readily accessible tissue for biopsy, blood tests and possibly stool tests that we can use aptamers to improve the accuracy of, and thinking about safe medicines and safe approaches that we can do in people who are diagnosed early, so dietary fibre. Also learning from existing clinical trial data where we know that drugs that have been tested have been very safe and well tolerated, then they would also be useful to test in the context of a blood test or a stool test where we could actually measure whether they were working properly. And really remember, these three things are to armour our GPs and our community diagnostic teams to be able to pick up the disease early so that we can start having these infographics like cancer medicine does, where we say, actually, we can do really well if we can diagnose early. So I'd really like to thank MND Scotland, first of all, for inviting me to talk to you today, but also for funding our work. They fund a clinical research fellowship for Christina Roberts, who's one of our team, and also some research that we're doing on precision medicine strategies, also to our other funders and our amazing team here at the University of Aberdeen. And please do reach out to us if you are interested in having a chat with us. Thank you very much.